Hello everyone. In this video, I'm going to discuss about the basics of platelets. So platelets are basically they are derived from the megakaryocytes. These are nothing but the cytoplasmic fragments of the megakaryocytes. So as you can see, this is the megakaryocyte, and these are some of the pseudopods that are originating from the megakaryocytes. So basically, these megakaryocytes they will produce pseudopods into the sinusoids which are present in the bone marrow. So sinusoids are nothing but specialized capillaries which we may find in the liver, in the spleen, and in the bone marrow. These sinusoids they have gaps between the endothelial cells. So basically, there are three types of capillaries. One is the continuous capillary that you find in most of the body parts, and second one is the fenestrated capillary, where we will have gaps between the endothelial cells, but the gaps are smaller compared to that we are getting in sinusoids. Fenestrated capillaries we'll study in the chapter of renal pathology. Those are found in kidney and also found in endocrine organs. Then we have sinusoids where the gaps between the endothelial cells are slightly larger, and sinusoids are found in liver, spleen, and bone marrow. Okay, so in the bone marrow sinusoids, these megakaryocytes they will produce pseudopods, and from these pseudopods there will be because of various mechanisms. The exact mechanism we are not very sure. Maybe some books write it is because of some caspase activation that will cause fragmentation of these pseudopods, and that will ultimately cause the formation of platelets. Now let us discuss a little bit more about the megakaryocytes. So how the megakaryocytes are produced? So everything starts from the pluripotent hematopoietic stem cells. After committing into the myeloid stem cells, so myeloid stem cells can give rise to erythropoiesis. They can go into the erythroid lineage. They can go into the megakaryocyte lineage. They can also go into the granulocyte monocyte lineage. Here we'll discuss about the megakaryocyte lineage. Now, this commitment towards the megakaryocyte lineage happens because of the glycoprotein thrombopoietin. As we have discussed during erythropoiesis, it is the erythropoietin that helps in the process of erythropoiesis. Similarly, thrombopoietin helps in the process of megakaryopoiesis and ultimately production of platelets. Now, this thrombopoietin is produced by kidney. These are predominantly produced by kidney and liver. For erythropoietin, we discussed that it is predominantly produced by the peritubular capillaries, the interstitial cells in the peritubular capillaries of the kidney. But thrombopoietin is produced by both kidney and liver. So they will produce thrombopoietin, and thrombopoietin will go and act on the myeloid stem cells to cause them to go into the megakaryocyte lineage. The first cell is megakaryoblast. Then we will have the pro-megakaryocyte, and ultimately they will have megakaryocyte. So these are the megakaryocyte. Megakaryocyte, from the name itself, can understand. Megakaryo means large nucleus. So these megakaryocytes will have a large nucleus. As you can see here, this will have a large nucleus. Remember, megakaryocytes are largest cell found in the bone marrow. These are around 20 to 25 micrometers. Okay. The irony is, even though megakaryocyte is the largest cell inside the bone marrow, platelets are the smallest cell in the peripheral blood. So platelets have around a diameter of 2 to 3 micrometers. These are the smallest cell. We have RBCs which are around 7 to 8 micrometer in diameter, but platelets are 2 to 3 micrometer in diameter. Now, this megakaryocyte will have a polyploid nucleus. Now, this concept is very important to understand because many times there is a confusion whether the megakaryocyte has a multinucleated, whether it is a multinucleated structure or it is a single nucleated structure. Remember, megakaryocytes have single nucleus, but it is polyploid. It is polyploid and it is multilobated. Okay, so it is multilobated. So single nucleus, but they will have multiple lobations. These multiple lobations happens because of polyploidy. That means megakaryocytes are polyploid in nature. Okay, so every cell in our body they are diploid. Diploid means it is 2n, but megakaryocytes have they are multiples of 2n. They can be 4n, it can be 16n, it can be 32n. Okay, so they are not diploid, they are polyploid. This polyploid nature happens, or this polyploidy happens because of a phenomenon that is known as endomitosis. Endomitosis. So what do you understand by endomitosis? Endomitosis means here the nucleus will not divide. Here the nucleus will not divide. Here the nucleus will not divide, but the content inside the nucleus. What we have inside the nucleus? We have the chromosomes. So the chromosomes will replicate and they will segregate without nuclear division. Okay, so chromosomes will replicate and segregate without nuclear division. So that's why they have a single nucleus, which is a large nucleus, which is having polyploid, and it is multi-lobated because the content inside the nucleus is more. Okay, so this is the process of endomitosis, and endomitosis is responsible for the polyploid nature of the nucleus, and that is responsible for the multi-lobated nucleus of the megakaryocytes. That is why the name large nucleated cell. And this is the largest cell inside the bone marrow, 20 to 25 micrometer in diameter. And they will extend the pseudopods into the sinusoids, and these pseudopods, due to various reasons, one of the reason is caspase activation. Maybe because of some caspase activation, there will be fragmentation of these pseudopods, and they will cause this formation of platelets. Okay, so if you see here, so this is again, this is a bone marrow aspirate image. This is bone marrow aspirate, and this is bone marrow biopsy. This is biopsy, this is aspirate. So in aspirate, you can identify these are the megakaryocytes, which are the larger cells, and you can also appreciate that they have multi-lobated nucleus. Okay, so this is also a megakaryocyte. In the bone marrow biopsy, also you can appreciate. So these are the megakaryocytes, which are the largest. These are the largest cells. And also one more point, you can identify that they are near the sinusoid. So this is a sinusoid because we are finding the red cells inside this. So sinusoids, as I told, these are capillaries. Okay, so capillaries will have the RBC. So you can appreciate that this is the sinusoid, and they are present near the sinusoids. So that's why they can extend their pseudopods into the sinusoids. Okay, so this is also one more sinusoid, and this is a megakaryocyte. Identifying megakaryocytes are important because when you will study about like MDS, when you study about MDS, myeloproliferative neoplasms, they will have certain megakaryocytic abnormalities that we have to identify in the bone marrow images. So what is this? Remember, there is always a confusion. If you are initially seeing the bone marrow slides, there is always a confusion between two cells, megakaryocyte and osteoblast. So this is basically osteoblast. Now, what is the difference? How it is different from the megakaryocyte? Remember, osteoclasts are multinucleated. These are multinucleated, but megakaryocyte will have single nucleus with multiple lobations. Osteoclast is multinucleated structure. As you can identify, these are multiple. They are multiple nucleus, and they will have more granular cytoplasm. The cytoplasm is more granular, and they have multiple nucleus. That is how you will differentiate a osteoclast from the megakaryocyte. More on osteoclast we'll study when we study about the bone pathology. Okay, so that's all about the megakaryocytes. Now we'll study, and now we'll see the platelets. So how will you identify platelets in the peripheral smear? So peripheral smear, we will see the platelets like this. So these are the platelets. These are very small. You can appreciate that if you take RBC of around 7 to 8 micrometer, the platelets are usually 2 to 3 micrometers. So they are 1/3 to 1/4 size of mature RBC. Sometimes you may find giant platelets. So sometimes the platelets are large, and sometimes the size of a platelet may be that of RBCs, maybe that of RBCs. So these are known as the giant platelets. You will find these giant platelets in a condition that is known as immune thrombocytopenia, ITP. We will discuss that more when we study about the platelet disorders. Okay. Now, if you see the ultrastructure of a platelet, it has a disc shape. As you can see, these are the normal platelets. It will have a disc shape. But when the platelets are activated, we'll study how they are activated. But when they are activated, the size will become bigger. And they will have cytoplasmic projections or the spikes. It is described as sea urchin. Now the picture is similar to sea urchin because of this spikes. Okay, so this is a resting platelet, which is a disc shape, but activated platelets will have larger size and they will have these projections. Now, if you see the platelet structure, as I told, these are disc shaped. But what else we need to understand? We have to read that there are some storage granules, and there are certain platelet receptors, and these are all important points that I am telling you. I will not describe all the details because those are not important. Whatever is required, I will tell only those points. So first we'll start with the secretory granules. Basically, the platelets have alpha granules and the delta granules. So this is alpha granule and this is the delta granule. Delta means dense. So it is dense. It is delta granule and it is dense. Now, what are the contents of delta granule? What are the contents of delta granule? So delta granule contain case. Case is calcium, basically the ionized calcium. It also has ADP and ATP. Sorry, ADP and ATP. It has serotonin and epinephrine. So delta granule can secrete calcium, ADP, ATP, serotonin, and epinephrine. Case. Alpha granules will secrete all the factors. Okay. So how will you remember? If you just remember delta granule, that is enough. Rest all the things will be produced by the alpha granules. But if you want to remember the alpha granule contents, these are all F. So von Willebrand factor, fibrinogen, fibronectin, platelet factor 4, platelet factor 3, platelet derived growth factor, TGF, that is transforming growth factor beta. So all the Fs, all the factors, and P-selectin. This is extra that you have to remember. So P-selectin and all the Fs are secreted by the alpha granule. Okay. So these are about the granules. Now we'll study what are the membrane receptors. What are the membrane receptors? So there are 5 important membrane receptors that you have to remember. The first one is GP1B9, second one is GP1A 2A, GP2B 3A. Then these 3 are glycoprotein receptors, and it has 2 G protein coupled receptors. As you must be knowing that G protein coupled receptors are 7 transmembrane receptors. So you can appreciate from the structures, these are 7 transmembrane receptors. These are the G protein coupled receptors. So these are P2Y1 or P2Y12 and PAR1. PAR1 is platelet activated receptor 1. Platelet activated receptor 1. Okay, so these are the 5 types of receptors we discussed. I told you about the 3 glycoprotein receptors: GP1B9, GP1A2A, GP2B3A, P2Y1. Okay, so those 3 are the glycoprotein receptors. Then we have the 2 G protein coupled receptors. One is the PAR1, that is platelet activated receptor 1, PAR1. Then we have the second G protein coupled receptor, that is P2Y1 or P2Y12. What are the functions of this receptor? We'll study that in the subsequent slides. Now platelets, what is the function of platelets? They will form the primary plug. So they will form the primary plug. Now whenever there is endothelial injury, the first response to endothelial injury is the vasoconstriction, and the next step is the primary plug formation, and primary plug formation happens because of the platelets. Now how these things happen? It has 4 steps. First step is platelet adhesion. Second step is platelet shape change. Third step is secretion of the granule contents, and fourth step is platelet aggregation. So these are the 4 steps of primary plug formation because of the platelets. Okay, now we'll see each step one by one. Let's start with adhesion. So whenever there is endothelial injury, now this endothelial injury will expose the subendothelial collagen. This is the subendothelial collagen, and this subendothelial collagen will have von Willebrand factor. Von Willebrand factor is produced by the endothelial cells, and also we have studied that von Willebrand factor is also produced by the alpha granule of the platelet. Okay, so von Willebrand factor will be attached to this endothelial surface, and this is recognized by the platelet. So this is the platelet. Okay, and this will recognize the von Willebrand factor with the help of a receptor, that is GP1B9. GP1B9. Okay, so GP1B9, this is for von Willebrand factor. This is for von Willebrand factor. Now platelets can also directly interact with the subendothelial collagen. It can directly interact with the subendothelial collagen with the help of another receptor, that is GP1A2A. 1A2A. Okay, so GP1A2A, it is for the subendothelial collagen. Now, so this is the process of adhesion. Now, once the platelet is adhered to the injured endothelium, what will happen? There will be shape change. As I told, the resting platelet is disc shaped, but once they are activated, they will have their shape change. So once there is adhesion of the platelet, there will be slight activation of the platelets, and they will become larger and they will form the spikes. As you can see here, it has become larger, and now it has produced some spikes also. Along with that, there are 2 important changes that you have to understand. The first one is the GP2B3A receptor will become activated. Now this receptor will become activated. What is the function of this receptor? That we will study later, but For the timing, you remember, whenever the platelets are activated, the GP2B3A receptors will become active. Okay. And the other thing that happens is phosphatidylserine, it will come from the inner surface of the membrane to the outer surface of the platelet membrane. Phosphatidylserine will come from the inner surface of the platelet membrane to the outer surface. This is what you must have studied also in the process of apoptosis. The process of apoptosis also, this phosphatidylserine will come to the outer surface and that will be recognized by the macrophages. But here, what is the function of this phenomenon? Now, because this phosphatidylserine will come to the surface, they will make the surface of the platelet negatively charged. Okay, because of this phospholipid, which is negatively charged, it will come to the surface of the platelets and it will make the surface of the platelet more negative. As it becomes more and more negative, it will be able to bind to the calcium ions. It will be able to bind to the calcium ions. Now, what is the function of this? Once calcium ions are bound to the platelet membrane, they help in the activation or the propagation of the coagulation pathway. Okay, the coagulation pathway, which helps in the secondary clot formation. So coagulation pathway will study later. For the timing, you remember, the platelet surface will become negative because of this phosphatidylserine, which will be able to now they'll be able to bind the calcium ions, and that will help in the process of the coagulation. Okay. Now, can you tell me calcium is coming from which granule of the platelet? Okay, so I hope you remember, case is coming from the delta granule. So case means case is coming from the delta granules, and we have discussed that case is coming from the case contains calcium, then A for ATP or ADP, S for serotonin, E for epinephrine. Okay, so calcium is coming from the delta granules. So this is what happens in the second step, that is shape change. Now, once once the platelets are activated, fully activated, now they will secrete some of the granule contents. Now they will secrete some of the granule contents. We'll discuss only the important granule contents that are worth discussing here. So they will secrete the thrombin. They will secrete thrombin, and they will secrete ADP. Now, thrombin, what is the function of thrombin? Now, thrombin will go and bind to the PAR1 receptor. They will go and bind to the PAR1 receptor, that is the platelet activating receptor. Okay. So, as you can see here, this is the PAR1 receptor. So this will bind this will bind to the thrombin. This will bind to the thrombin. Okay. Then what is the other function of thrombin? Okay. Other function of thrombin is they also help in formation of secondary plug. Secondary plug is made by the coagulation pathway system. We'll discuss that in the next lecture about the coagulation pathway and how they make the secondary plug. So thrombin has various functions, but now you just remember that thrombin, it can bind to the PAR1 receptor on the platelet, and through that it can cause activation of the platelet, and it can also help in formation of the secondary plug. How it helps in formation of secondary plug, that we'll discuss in the next lecture. Okay. Platelets also will release ADP. Now, this ADP can bind to the P2Y1 and P2Y12 receptors. Both these receptors are G protein coupled receptors. Now, ADP can bind to these receptors. After binding to these receptors, they can cause recruitment of additional platelets. So, binding of thrombin will cause activation. Binding of ADP also will cause activation, but apart from that, they can cause recruitment of additional platelets. So, more and more platelets will come. Okay, more and more platelets will come. Now, if like a big number of platelets have come, now they want to attach to each other. They want to aggregate so that they can make the plug. How they will aggregate? Who will activate this process of aggregation? So one of the important factors is thromboxane A2. Now, thromboxane A2 is not stored in the storage granules inside the platelet. Thromboxane A2 will be synthesized from the platelet and it will be released. Okay, so thromboxane A2 will be released, and this thromboxane A2, this helps in aggregation of the platelets. This helps in aggregation of the platelets. The thromboxane is synthesized from the arachidonic acid, which is present in the phospholipid bilayer with the help of cyclooxygenase. So this is important to understand. This cyclooxygenase helps in forming this thromboxane A2 from the arachidonic acid, which is present in the phospholipid bilayer. This you must have studied in the chapter of inflammation also. The process of prostaglandin synthesis. Okay. Now this thromboxane A2 will help in aggregation. Okay. So we'll just complete this. So what is the what will bind to the P2Y1 or P2Y12 receptor? So ADP will come and bind to this receptor. Okay. So now coming to the last step is aggregation. So aggregation means attachment of platelets with each other. Now this happens with the help of fibrinogen. So fibrinogen is a bivalent structure. On the one end, they can attach to. I mean, on either end, they can bind two platelets and they can cause their aggregation. This happens with the help of GP2B3A receptor. So this is the fibrinogen, which is attaching to the GP2B3A receptor on one platelet, and on the other hand, it is also attaching the other platelet with the help of this GP2B3A receptor. So GP2B3A receptor is for fibrinogen. This is for fibrinogen. Okay. So now you know the function of all the receptors. Okay. And this is the process of primary plug formation. As there will be more and more aggregation, they will make the primary plug. After primary plug, there will be secondary plug that we'll discuss in the next lecture. So this is about the platelet primary plug formation. Now we'll just summarize whatever we have discussed. We have discussed all these receptors. We have discussed all these ligands of the receptors. Now we'll see what are the abnormalities that can happen if there is some kind of mutation in these receptors. Okay, so we'll start with GP1B9 receptor. If there is a mutation in GP1B9 receptor, it will cause Bernard-Soulier syndrome. So that means it will Bernard-Soulier syndrome. It's a disorder where there is defective platelet adhesion. So adhesion is defective because GP1B9 is helping in adhesion. Next one is GP2B3A. GP2B3A deficiency or mutation, it can cause a condition that is known as Glanzmann thrombasthenia. It will cause Glanzmann thrombasthenia. So GP2B3A, I told you this is required for the aggregation. So in Glanzmann thrombasthenia, the aggregation is defective. Adhesion is not defective, aggregation is defective. In Bernard-Soulier, the adhesion is defective. Then if you see here, if this process is affected, I mean the flipping of phosphatidylserine from the inner surface to outer surface, if this process is affected, this happens in a condition that is known as Scott syndrome. So in Scott syndrome, this flipping of phosphatidylserine from the inner surface to outer surface is defective. Okay. So these are some of the disorders. Now we'll see some of the drugs which are acting on these various pathways. Those are used as antiplatelet drugs in various conditions. We have certain GP2B3A blockers. Those are abciximab. Example is abciximab. I mean, there are various other drugs also. I'm just giving one example. Similarly, we have blockers for P2Y12 receptor, like clopidogrel, eclopidine. All those things we will study in pharmacology. Similarly, there is a drug which can block this PAR1, that is platelet activity receptor 1. So that drug is Vorapaxar. So PAR1 is the thrombin receptor, and that can be blocked by this drug Vorapaxar. Similarly, aspirin is a drug. Aspirin can inhibit this. Aspirin is also used as antiplatelet agent because it can inhibit this cyclooxygenase. Cyclooxygenase is responsible for thromboxane A2 production, which helps in platelet aggregation. Okay. Thromboxane A2 also helps in, it will also cause vasoconstriction. And the receptor for thromboxane A2 is also a G protein coupled receptor. That is the GQ type of G protein coupled receptor that helps in vasoconstriction. Okay, so that's all about platelets.